Hello, we're glad you've joined us for this live webinar, GenomeFIRST, a new paradigm for the return of genomic results. I am Christina Mahalik of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars, advancing scientific collaboration and learning. To learn more, visit labroots.com. Let's get started. You can pose questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them in the Q&A box, which will open when you click the green Q&A button at the lower left of the presentation window. Questions will be answered after the presentation. To enlarge the slide window, click on the screen icon in the lower right-hand corner of the slide window. If you experience technical problems seeing or hearing the presentation, just click on the support button found at the top right of the presentation window, or report your problem by clicking on the green Q&A button at the lower left of the screen. This is an educational webinar and thus offers free continuing education credits. After the webinar is over, please click on the CE button located in the bottom left-hand corner of your webpage and follow the process of obtaining your credits. I am delighted to present today's speaker, Marc Williams, MD, Professor, Director, Genomic Medicine Institute, Geisinger Health System. Dr. Williams' interests have been to study the impact of implementing genetics, genomics, and family history in routine clinical care. Successful implementation requires the application of many disparate elements, including technology, assessment, modeling, and decision analysis, the science of behavioral change, quality improvement, knowledge management, informatics, healthcare economics, and patient-centered outcomes, all of which are components of the emerging discipline of implementation science. Dr. Williams is also interested in defining the value proposition of new genomic technologies, with value beginning simplistically represented as outcomes costs. His research to date has examined the impact of family history on provider experience, the role of informatics to provide point-of-care, just-in-time education resources, and passive decision support to clinicians regarding genetic topics, impact of tumor-based screening of Lynch syndrome, including extensive modeling to optimize the efficiency of the program, the use of query tools to obtain information on genetic conditions from electronic data warehouses, and application of the tools of quality improvements to facilitate implementation of evidence-based best practices in genetics and genomics. Dr. Williams is beginning to explore how we can get information from patients about their preferences, including an assessment of patient locations on the state of change continuum and the use of those preferences to reconcile priorities regarding preventative and therapeutic interventions with the patient's provider to see if that will improve satisfaction for both and increase compliance with the recommendations, leading to measurable improvements in outcomes and improved value. Once again, I am delighted to introduce today's speaker, Dr. Williams. You may now begin your presentation.
Thank you very much for that very nice introduction and for the opportunity to present a seminar today. As mentioned, we're going to be talking about a new paradigm in genomics, but before I get into that, I wanted to personalize this presentation a bit and talk about a face of our program. This is a 53-year-old woman who was enrolled in our MyCode Community Health Initiative. She had a history of basal cell carcinoma removed at age 33. She's currently undergoing treatment for Crohn's disease. She has received regular medical care but has declined mammography for the last 5 years. She is the primary caregiver for her grandchildren. So we're going to come back to this face at the end of the presentation to talk about the impact that this can have on an individual. So as an overview for today's talk, I'm going to briefly discuss terms that are in current use and reflect a bit of the philosophic approach to precision medicine that we're trying to implement here at Geisinger. I also want to spend a little bit of time discussing the construct for assessing value in healthcare, since this is something that is becoming increasingly important and is not something that we're exposed to very much. I do apologize. I know that there are global attendees for this seminar. This will have a U.S.-centric approach. However, I think the concept of value is international. I am going to introduce the GenomeFIRST concept and then present some data from our Return to Results program and frame that within the value construct. There are a number of different words or terms that have been used to describe some of the emerging technologies in practice, including genomic medicine, personalized medicine, individualized medicine, and precision medicine. So one might reasonably ask whether there's any difference between these. I believe there are some differences, and I'm going to spend a bit of time talking about that because I think it is important. Genomic medicine, which is primarily what I'm doing, includes traditional single gene disorders, or what we used to call genetics, or still call genetics for that matter, the analysis of the whole genome, which is genomics, also analyses of subsets of the whole genome, which would include the exome or the pharmacogenome, but also importantly includes family history, which is still, even in the era of next generation sequencing, is critically important in terms of understanding and contextualizing risk for an individual patient's development of a condition. Now, personalized medicine, I went to the definitive source of definitions, Wikipedia, and they define personalized medicine as the use of information and data from a patient's genotype or level of gene expression to stratify disease, select a medication, provide a therapy, or initiate a preventative measure that is particularly suited to that patient at the time of administration. I think this is a fine definition. I think it's one that many of my colleagues would promote. However, I think it's dead wrong. And it's somewhat perhaps anachronistic for me as a geneticist to promote a definition of personalized medicine that doesn't include any reference to genetics or genomics, but this definition from Pauker and Kassir in 1987 to me really sums up what we're trying to do in personalized medicine. They, in their article, state, personalized medicine is the practice of clinical decision making such that the decisions made maximize the outcomes that the patient most cares about and minimizes those that the patient fears the most, on the basis of as much knowledge about the individual status as available. I think this definition is really important for two specific reasons. First of all, not all patients will have the same outcomes that they prioritize. So take example, someone with stage 4 cancer. One individual may prefer palliative care, pain control, so that they can spend their remaining time comfortable and interacting with their family, whereas others may want every exploratory investigative treatment that's possibly available to them. If we don't understand the outcomes that the patient desires, then we really can't personalize their care. So this is really, person-centered, patient-centered medicine. And then the second thing I like about the definition is the last statement, as much knowledge about the individual status is available. So it doesn't say that any certain type of information, like genomic information, is better than any other information. Whatever information is necessary to make decisions to achieve the outcomes that are desired are relevant. And so we can't focus too much on one particular type of knowledge. Now, that being said, the term precision medicine more recently has been emerging into use, although it actually has almost 10 years of use in certain circles. I tend to prefer the use of precision medicine because clinicians have always practiced personalized medicine. And so I would get tired of people saying, when I said, we've got this new concept, personalized medicine, saying, well, what have I been doing all these years? impersonalized medicine? I said, no, it's really that we've been practicing intuitive medicine. And what is meant by that is that this is the care of conditions that can be diagnosed only by symptoms and only treated with therapies whose efficacy is uncertain, and watching for an empiric response. The reason why the efficacy is uncertain is because our interventions are tested on populations. And so therapies that move into practice, on balance, have more people in the population that have an appropriate response than those that don't have a response or have an adverse event. But for an individual, we can't determine a priori whether they're going to be a responder, a non-responder, or will have an adverse event. And that's why we have to wait for this empiric response. So essentially what we've been doing is empiric trial and error. And so in his book, The Innovator's Prescription, A Disruptive Solution for Healthcare, Clay Christensen proposed the idea of precision medicine, which he defines as the provision of care for diseases that can be precisely diagnosed, whose causes are understood, and which consequently can be treated with rules-based therapies that are predictably effective. And I think this is where we really want to go with precision medicine. And I do expect that genomics is going to play a key role in this, and I'll be able to illustrate this to some degree later in the talk. Now I want to move to discussing the concept of value. As noted in the introduction, we can crudely think of value as some relationship between outcomes and the cost of care. And so if we think about outcomes from the patient's perspective, which is what Michael Porter suggests we have to do if we're considering value, is that there are medical or health outcomes, which is what is the response to a treatment or a preventative strategy, how safe is the intervention that we're doing. There are also service outcomes that are important to the patient. How many visits does it take to achieve a given health outcome? How much does this disrupt my life routine? How satisfied am I with the care? How empowered am I to participate in my care? There's also an outcome that relates to the to information. How do we convey information of importance to patients? Now, we've tended to value this very highly in genetics, frankly, because we haven't had a whole lot of treatments that we've been able to implement in the past. But it's been noted that this is very difficult to value economically. And we have this tension between what we might characterize as personal utility, which is this information is important for me to make decisions, versus that we just can't spend an infinite amount of money on healthcare. So how much personal utility or information can we afford in the construct of healthcare costs that are reaching their upper limits? I think it's also fair to say that in general we do a very poor job of measuring the cost of services. I can frequently get an answer when I say, what does it cost to do that? But what is really being given to me is, what do we charge for it, which is very different from the cost. So this is another area that we have to pay attention to. Now, I try and think about these things in a very simplistic way, and so I've constructed this 3x3 table where we can see on the top there's cost of care, which can decrease, it can be unchanged, or it can increase. And then our medical and or service outcomes can improve, be unchanged, or they can worsen. And so let's use some genomic examples to kind of populate this table. So HLA-B5701 is a genotype that puts individuals at very high risk for developing a severe cutaneous adverse event related to the use of abacavir, an antiretroviral medication. So if we test for this particular genotype prior to the use of abacavir, this is a very high value test because it definitely improves outcomes by avoiding these severe adverse events, and it decreases the cost of care because we don't have to pay for the medical care that would be experienced in an individual were they to have one of these events. Now, another situation that we frequently encounter in healthcare is a new treatment that is quite expensive, but it does improve outcomes. So an example of this is the drug imatinib, which is a treatment for chronic myelogenous leukemia. Prior to the development of imatinib, we had no treatments for CML. So when imatinib was introduced, we had a treatment for an untreatable disease, but it's a very expensive medication. But I think society, at least if we go by the imperfect metric of coverage by insurance companies, has said that there is sufficient improvement in health outcomes to justify the increased cost in care, because payers are covering the use of imatinib for chronic myelogenous leukemia. So not all improvements of outcomes will come with a decreased or unchanged cost, and we just have to balance the value that we're getting based on the improvement in outcomes compared to the increased cost. Now, unfortunately, what we do a lot of Unfortunately, what we do a lot of in healthcare, apologize for the little glitch with the server there, is that we apply technologies indiscriminately. So there's another HLA type, 1502, that is associated with a increased risk of severe cutaneous adverse events to patients that are given carbamazepine. This particular HLA type is very prevalent in Asian populations, particularly populations that derive from the Han Chinese, but is almost not seen in African American and Caucasian populations. If we were to decide to do population screening for this HLA type for every person in the United States, this would be a very poor value. It would inject a lot of cost. I say that health outcomes would worsen because with low prevalence, a lot of the positive tests would in fact be false positives, meaning that we would not be giving appropriate therapies for individuals who would benefit from the use of a drug like carbamazepine. But also there aren't that many people that are exposed to carbamazepine. So this type of indiscriminate use of a technology can increase costs and worsen outcomes, and we want to try and avoid this as best we can. But unfortunately, with a lot of emerging new technologies, we do not think about these types of issues, and as a consequence, we end up getting very poor value. Now, this is important because if we look at value in the United States, here's a list of healthcare expenditures per capita in a group of developed countries. And you can see here that the United States is well ahead of the rest of the developed world in terms of how much money we spend on healthcare per capita. Now, that may be a good thing if we had superior outcomes. The unfortunate thing is that using some metrics that we think would be relatively important, which is life expectancy, infant mortality, and potential years of life lost, the United States ranks around 17th in these metrics compared to other developed countries, where if you look at Japan, which has the lowest expenditure per capita, they in fact have outcomes that are number 1 or number 2. And so while we can argue how much money is appropriate to spend in healthcare, we're not getting very good value in the United States for the money that we are expending. Now, it's important to note that the excess in money that we're spending, actually, we can note that spending in social determinants to improve access to care and improve the availability of healthcare and preventive services, which is built into many of our countries' healthcare systems, is not something that is well integrated in the United States. And so, as a consequence, the healthcare sector ends up bearing a lot of this burden. So that could be a whole talk in itself, but suffice it to say, we have some work to do. Now, in genomics, we have very little information at the present time about the value of this intervention. In traditional genetics, we have the challenge that we have a lot of disorders that are rare individually, but are collectively common when you aggregate them together. But the problem is that you have a very heterogeneous set of outcomes for these various disorders. But rather than making that an apology, the reality is that we've also not done any concerted efforts to generate evidence of benefit. And that's something that we must do, because the healthcare system is moving to a system of value-based assessments. And if we as a field don't define value and outcomes, then someone will do that for us. So we have to determine how to assess the value of genomic medicine. And at least from my perspective, one of the areas where there's some potential is the fact that genomic information, germline genomic information, doesn't change over the course of a patient's lifetime for all intents and purposes. And so there's the opportunity to reuse this information over a lifetime. So the advantages of this is it spreads the cost out over a lifetime of care, which avoids the need to do repeat testing, which could conceivably reduce duplication and waste. Having the information available means that it can be used as soon as it's needed to make healthcare decisions, as opposed to saying, well, I want to use this drug, I know there's a pharmacogenomic variant that's important, I have to send off a test, so I can't prescribe the drug. That's not something that works very well in the healthcare sector. And of course, as I alluded to earlier, we could potentially have much more precise pharmacologic therapy and improve the safety of medications, as well as choosing the best tolerated and most effective therapy related to pharmacogenomic determinants combined with clinical determinants of drug response and adverse events. Now, there's a lot of questions that go along with whether or not we can do it. Where do we store the information? More importantly, how can we make sure that that information is available wherever the patient receives care? In the United States, we do not have a national health system. We have a bunch of different healthcare delivery areas, and that information doesn't move well from one system to another. So that's a big problem, and it's a problem even in countries where there's a national health system. Right now, we have very little evidence of benefit or evidence of things that don't work that we shouldn't be doing, and so we have to generate that evidence. Also, our knowledge of genomics right now is in its early infancy, and there's the vast majority of the genome, we have no idea what it does and what impact it has on health. And so we have to have a way to update this information over time. We must be able to present this information when it's needed at the point of care, so that when a medical decision is being made, that information is instantly available. We also have to recognize the potential for discrimination, that this information could be used for negative purposes. There are some protections in place in the United States about the misuse of genetic information to discriminate for health insurance and for employment, but for things like life insurance and long-term disability, there are no protections at the present time. Now, I want to present value from rather the national perspective to anticipate a question that some of you may have, which is why would a healthcare system like Geisinger choose to invest in genomics? So this is a map of our healthcare system for those of you who are familiar with U.S. geography. We encompass most of central Pennsylvania, and we also now have a healthcare system in Atlantic City, New Jersey. And just to demonstrate here, this is where I am currently residing, Danville, Pennsylvania, which is a town of about 8,000 people that has a healthcare system whose campus here employs 14,000. So it's an interesting model, interesting place to practice. And the integration of our system provides some interesting opportunities to study value. And we talk about the sweet spot, which is where we think that partnership with the clinical enterprise and innovation can really play a huge role. So we have our clinic, which is represented by the bubble on the left, but we also own a payer, the Geisinger Health Plan, which pays for care. And we're also an employer of about 30,000 people, and we serve as the payer for that group as well. So in common to these different bubbles are things like population management, our provider structure, our infrastructure, and our electronic health record. And if we can find ways to align objectives across these different areas, that's where we can really have the greatest impact. That is the sweet spot. And so that's what we strive to do. So when we think about genomics, we think about how can we make this work within our sweet spot. Now finally, what you've all been waiting for, a discussion of our GenomeFIRST approach. And GenomeFIRST is a different type of a paradigm where the prompt for the clinical encounter is a DNA variant. Usually in clinical medicine, the patient presents with a sign or a symptom or a constellation of signs and symptoms, and that initiates the diagnostic process. And then we generate testing as a result, sometimes genetic testing if it turns out to be something that's relevant to genetics. But in this case, what we're doing is we're saying there's a variant in the genome that we think puts an individual at very high risk for developing a condition that we can do something about. And as a consequence, we will contact that individual on the basis of the DNA variant. So genome first, as opposed to phenome or sign and symptom first approach. Now we can do this because we are involved in a collaborative project where we're moving towards having approximately 250,000 of our patients who have exome sequencing done. This is being done in the context of a large research project, and as part of that, we are looking through those exomes to identify individuals that have what we determine to be actionable results in genes that are part of the known genetic conditions. We take that data and then we will return the results to patients and their providers. And in addition to that, we will support the patients and providers with long-term follow-up related to the results and help assist with management planning. So as part of this, we have to operationalize a scalable return of results infrastructure within our integrated healthcare delivery system. So I had alluded to MyCode earlier. MyCode is a community-based health initiative where individuals are consented to participate. The consent consists of a broad consent to research, a collection of a specimen, in most cases just a blood specimen, where we extract DNA and then maintain serum within the biobank. But then the individuals also consent to return of results for medically actionable indications, and also for recontact for specific research studies where we want to get additional clinical information. This has been an extremely successful program at Geisinger, and we have about a 90% success rate when we approach people to consent in the project. Very high rates of buy-in from the community. At present, we're approaching 140,000 individuals who have been consented. We have specimens available on approaching 100,000 and have completed exome sequencing on about 60,000 individuals. We have a list currently of 76 genes that are inclusive of the initial ACMG56 gene list, and this is associated with 27 conditions. We have 3 top priority conditions that have been identified as being the leading candidates for public health intervention or population health intervention in genomics, and that is familial hypercholesterolemia, Lynch syndrome, and hereditary breast and ovarian cancer. As I mentioned, our biorepository started in 2007. It followed extensive consultation with our patients and other stakeholders, and that really informed the design of the project. And we recently defined it as a community health initiative to reflect the fact that we can now use information derived from the project as part of our population health initiative. As I mentioned, the Geisinger 76 focuses on 27 conditions. It builds on the ACMG incidentals finding list from 2013. These are heavily focused on cancer predisposition genes such as BRCA1 and 2, cardiovascular disease including familial hypercholesterolemia and hypertrophic cardiomyopathy, malignant hyperthermia, and a couple of rarer genetic disorders for which there are good interventions, hereditary hemorrhagic telangiectasia and ornithine transcarbamylase deficiency. Now, as we look at the information, I should have mentioned, and I apologize here, this publication in Science from December of last year provides details on this, and so I would recommend that for your reading if you would like additional information. As I mentioned, these 3 conditions, FH, hereditary breast and ovarian cancer, and Lynch syndrome, are the top priority conditions. It turns out that about 1 in 100 individuals has a pathogenic or likely pathogenic variant in one of these three genes. In genes in one of these three conditions. There are multiple genes, as noted here, that can be associated with the three conditions. So FH is associated with early onset coronary artery disease and stroke, and we can utilize targeted screening and aggressive medical management in individuals with this condition. Hereditary breast and ovarian cancer syndrome is amenable to targeted screening and prophylactic medical and surgical interventions, so prophylactic mastectomy or a salpingo oophorectomy, use of hormone related therapies to reduce risk can all be utilized. And then Lynch syndrome, which is an early predisposition to colorectal and uterine cancers, particularly for colorectal cancer, there's very effective screening and management through the use of colonoscopy, which not only identifies the precancerous lesions but removes them. Now, when we find a pathogenic or likely pathogenic variant, that initiates a gene-specific evaluation that includes a history, which includes family history as well, an examination where relevant, if there are signs or symptoms that could be looked for or found on physical examination, potentially additional testing, and then consultation with specialties. This is outlined and taken from an article by Mike Murray in Genetics and Medicine in August of 2016. And we recognize that there are going to be 5 groups that could be identified as a result of this particular approach. Group 1 is a group where when we return the result, they say yes, and I'll use the example of BRCA1 here. We say, we found a variant in BRCA1, and they say, yes, we knew that because I had a cancer and my physician thought that I could be at risk. I did clinical testing, and we found the same variant through clinical testing. So this is essentially confirming the previous genotype and phenotype that's been observed. Now, there's still value to this because what we found is that even in these individuals who have had clinical testing, they've not always been appropriately informed about follow-up that would be most appropriate, and more importantly, that family members might be at risk. So we've found some care gaps in this group, even though they already knew they had the diagnosis. Group 2, this is a group where an individual has had a condition or phenotype related to the genetic variant, so again, using BRCA as an example, an individual with breast cancer. But for whatever reason, they've not undergone clinical testing. Perhaps they don't have a family history that is suggestive. Perhaps they did, but the family history was not obtained, or the clinician did not actually recommend the testing. In this case, we would say, we now have an explanation for why you developed the condition that you developed, and here are some additional recommendations for your care that should be done based on this new information. Group 3 is a group of individuals where at the time of the return of results, there is no evidence of a clinical phenotype that has been detected through routine medical care. But when we say there are certain screening things that we would recommend you do, let's say a mammogram for an individual with a BRCA variant, we identify an early breast cancer. So this individual, in fact, had the condition, had a phenotype, but did not know that they had it because there were no clinical symptoms that were noted. And so we really make an early diagnosis here where hopefully we would be able to have more effective therapies. Now, there are 2 groups that at the time of the initial return of results do not have any evidence of disease, even when we do the appropriate surveillance. Group 4 would be one where over time, as we do the surveillance, which again in BRCA might be mammograms and breast MRI, would develop an early cancer over time. And as a consequence, that would essentially move them then into a group 3. Group 5 is the most problematic group. We know we're going to be returning results to individuals who will never develop the condition for which they're at risk, because none of these conditions are fully penetrant. Even in highly penetrant families, there may be 20 to 30% of individuals that carry a BRCA pathogenic variant who never develop a cancer. So we're going to be increasing the intensity of medical care for these individuals who will not have any benefit from it because they would never have developed the condition. And so this really is sort of the negative value. Now, we don't have a lot of choice right now because we don't understand why these individuals don't develop the problem. It may be that over time we will develop information that would allow us to say, you know what, you have this variant, but you're not going to develop the problem. Therefore, we don't need to do intensive intervention for you. But the other thing to point out about the value proposition is that when we consider the patient in genetics or genomics, it's not just the patient, but it's that patient's family. And so even though that index patient may not develop the condition, it is quite possible that family members that carry that pathogenic variant could develop the condition and would achieve value from the return of that result, even though the index case does not. So this is something that we're going to be studying and collecting outcomes around over time. So we have to define the outcomes, and it's important when we think about outcomes to define them from the get-go. So again, what are the health outcomes? These will fall into 3 different broad categories. Process outcomes are ones that are the easiest to measure. If we recommend that an individual gets a mammogram or gets a lipid panel, and they got it, and so we can check off the box. Yes, they followed that recommendation. Intermediate outcomes are results that relate to the health outcome of interest, but are not a health outcome in and of themselves. The best example here would be the LDL cholesterol level in FH. So if we do that lipid level and we determine that the LDL cholesterol is elevated, that would indicate increased risk for cardiovascular disease, and we would have a target that we could treat. And so that's a very good intermediate outcome because there's a good chain of evidence that suggests that if we use certain medications to lower the LDL cholesterol, that will reduce the health outcome of interest, which in this case would be cardiovascular events. And so that's a typical health outcome, but other health outcomes could include breast cancer, ovarian cancer, colorectal cancer, etc. We also have a number of patient-centered outcomes that would include satisfaction, patient engagement, information, as we talked about earlier, access to care, and how do you feel about yourself, self-assessed well-being, which is actually a very strong predictor of healthcare utilization. And then there are outcomes from the system perspective. What are the costs that we incur by doing this? What are potentially avoided costs from earlier interventions? What impact does this information have on overall utilization? How about patient experience? We are now being graded on what patients think about our system, and we have reimbursement that's tied to that. Could this system decrease patient experience, which would cost us money? And then there's the marketing outcome that is important for systems, which is how does this impact our visibility with our peers and our reputation? So all of these things have to be accounted for, and we're in the process of building out ways to capture the different outcomes for the conditions of interest. Now this is a slide that identifies how we're going to return these results. So this gets at the infrastructure issues that I talked about before. And I'm just going to walk through this from top to bottom. So when we get a pathogenic variant that passes our criteria for return, that result is initially sent to the primary care provider of the participant. There are 5 business days that are allowed to go by. After that time, the clinical genomics group sends a message to the patient through the electronic health record, through the patient portal. For those patients who have a patient portal account, for those that don't, we send a letter. And then we allow 5 to 10 business days before we would directly contact the patient with a phone call. Now, in many cases, the primary care provider in that first encounter will take the initiative, will contact the participant, and will schedule an encounter either with themselves or potentially in conjunction with the clinical genomics group. And we facilitate that, scheduling that appointment. If we are unable to contact the participant through any of these methods, then we send a letter, registered letter, with the result to the patient. And we document in the electronic health record that we were unable to contact the patient. Now, we've had some circumstances where we've had participants contact us after receiving the letter, in which case then we do the disclosure phone script, and we also start to take the family history and provide an identifier to the family history so that we can manage these pedigrees. We send the result and support materials to the patient, and then we allow the participant to have their follow-up with their primary care provider, with clinical genomics, or with both. And our clinical genomics group assists with any referrals that are necessary, and ultimately, when recommendations are generated, we work with the primary care provider and condition-specific specialists to make sure that the recommendations are clearly communicated to the participant, and then monitor to see whether the recommendations are followed up on. So we want to close that loop and make sure that information is actively worked on. Apologize for the drink. I have a bit of a cold and I'm starting to dry out. This is probably not well visible, but you can see that as of February 1st, we have returned 241 results to 239 patients. There are two unfortunate individuals who have received two results as a part of this, but we post these publicly, and so the URL that's given on the slide will take you directly to this page, which is updated on a monthly basis. And you can see on the left-hand column that we have conditions. So we have hereditary breast and ovarian cancer, which consists of over half of the returns that we've done so far, familial hypercholesterolemia, et cetera, down the list to some of the rare disorders. So this is something that, again, we want to make publicly available, and hope that our experience is able to inform others that are interested in moving into this area. Now, I want to provide some specific examples of how we think this type of a genomic return of results can really improve care. I want to focus on some work that we've been doing in familial hypercholesterolemia. Right now, on our Geisinger 76, there are 3 genes that are known to be associated with FH. LDLR, the LDL receptor, is by far and away the most common gene that's been identified in prior studies. But the genes ApoB and PCSK9 are also known to be associated with FH. In our population, we find a prevalence of these at approximately 1 in 200. And as I mentioned, the clinical risk here is early onset coronary artery disease and stroke, and that we have very effective management strategies related to screening and medical management. So this is an overview from our 50,000, our first analysis. And so what we find here is that in just over 50,000 sequenced participants, we identified 229 individuals with a pathogenic or likely pathogenic variant. And I should mention that we use very strict criteria for calling out a variant. This would be either a star 2 or a star 3 level evidence in ClinVar, or in the case of LDLR, where loss of function is the mechanism of action, we apply loss of function analysis to novel variants that may not be reported in databases as likely pathogenic or pathogenic. These variants also pass through 2 levels of review by the laboratory that is doing the confirmatory testing in a CLIA-certified laboratory. and also through our own bioinformatic pipeline. So two independent sets of groups come to the same conclusion that this is a pathogenic or likely pathogenic variant. And you can see that the prevalence here is about 1 in 222. And you can also see that for the most part we've done ascertainment from general clinics. However, we do have a subset that are coming out of the cardiac catheterization lab, and as you would expect, the prevalence in the cardiac catheterization population is much higher, about twice as high as you would expect compared to other sites. Now, the interesting thing is when we look at the prevalence of variants based on the maximum documented LDL cholesterol in the electronic health record. This is, what I mean by this is in lipid profiles, if an individual's had multiple lipid profiles, we look at the highest LDL cholesterol that is noted. You can see what you would expect to see, which is if you have a relatively low LDL cholesterol, less than 155, which is the majority of the population, we see a prevalence of about 1 in 600 for pathogenic variants. Whereas if you move to the other end, LDL cholesterols that are extremely high, greater than 330, the prevalence here is 1 in 3. So this is reassuring that we're seeing exactly the sort of signal that you would expect to see with increasing LDL cholesterol. But it is a bit dismaying that with individuals with this high of an LDL, we're only identifying 1 in 3 who have pathogenic variants. And so that means we have some work to do in terms of our variant calling and potentially identifying other genes that might be involved in LDL cholesterol metabolism. Now, if we look at our LDL range in FH variant negative versus FH variant positive in our population, you can see that there is considerable overlap. The blue, which is the FH variant positive, clearly skews to the right, with some individuals with extraordinarily high LDL cholesterol. But you can note a huge area of overlap, and even individuals with FH positive variants can sometimes have very low LDL cholesterols. Some of these are in individuals that are undergoing treatment, but we found significant numbers that have never had a treatment that have LDL cholesterols that are in the normal range, which is something that we'll talk about in just a bit. Now, it's important to recognize that if we only use LDL as a criteria for FH, which is what is currently recommended, that it definitely increases the false negative rate in adults. And so this was from a publication by Starr in 2008. And essentially, you can see the same type of pattern that we're observing in our families, that in both in the pediatric population and in the adult population, there are a significant number of individuals with FH who have normal LDL cholesterol levels, and as a consequence will not be identified. And this is a significant issue for reasons that we'll discuss in just a bit. This is just one of the FH diagnostic criteria, the Simon-Broom criteria, that in under 15 gives an LDL threshold of 155 and an LDL in adults of greater than 190. And so this is the cutoff. In children, you can see significant numbers of the FH population below that cutoff. And then again, here in adults, more than half of adults are under that cutoff. So LDL by itself is not nearly as sensitive as we would like it to be. Again, if we apply these cutoffs in our population, you see exactly the same pattern. Now, what's the impact? So this is from a publication in the same issue of Science that focused on FH. And what you can see from our criteria when we mine our EHR data looking for cardiovascular events, specifically coronary artery disease, that if you look at individuals with a FH variant compared to individuals without a variant, there is a very large signal with a relative risk, or odds ratio rather, of 2.6, with a p-value that's extraordinarily high. And if we focus on the most pathogenic variants, which are the loss of function LDLR variants, you can see here that the odds ratio is 5.5. Now, ApoB and PCSK9 are much less frequent, which is why, even though we're detecting a signal, the confidence intervals are much broader. Now, what's interesting is if we look at premature coronary artery disease as defined by the American Heart Association, you can see that these odds ratios go up. So now, if we look at the loss of function for LDLR, that odds ratio is 10 times with a p-value of 10 to the minus 19. So this is a huge signal of the importance of these FH variants that we can determine out of our population. So that led us to evaluate, well, how are these people being treated? Are they being appropriately managed? So out of the 229 patients that we identified with one of these 35 variants, 45 of them we excluded because they had not had an LDL cholesterol within the last 5 years. Now, that doesn't mean they didn't have an LDL cholesterol in the last 5 years, because it could have occurred outside of the system, in which case we would not see that in our electronic health record. 14 of the individuals had also died between the time they enrolled in the program and this analysis. So ultimately, we had 170 patients that we analyzed. The median age was 61.5, 61% females, and 96% white. This matches our overall MyCode population to a T, so it does not seem like we have ascertainment issues here. One thing that's a little bit unusual is you'll notice that even though I was saying that ApoB was somewhat rarer than LDL, that we have about equal numbers here, and that reflects a family where we have multiple members of the family that are in our MyCode population that have a familial ApoB variant. So that skews this to some degree. This is a plot that looks at our current statin usage. You can see that a third of these individuals are not currently on statins, which is the first line recommended therapy for individuals with FH. Now, some of these individuals had a record of having been on a statin in the past, but some of them are clearly not adherent to that. So about 2/3 are on a statin therapy, but if you notice, less than half are on high-intensity statins, about 20% are on moderate-intensity statins. That may or may not be appropriate given the LDL control. And this slide gets at that. And what you can see here is that the LDL cholesterol goal is, in an individual with FH, is an LDL cholesterol less than 100. And what you can see is only 21%, at least based on the current study, has a LDL of less than 100. We do see a treatment effect, however, because the sort of the median of the bell-shaped curve here is skewed to the right in individuals when you look at their lifetime maximum compared to individuals that are under treatment, where it's more towards the left, which is what we would hope to see. But you can see that there's a substantial number of patients that are not at the goal that we would like them to have. And this is why it's important to identify individuals. This is a study by Kara et al. From last year that showed that even in individuals with FH who have very low LDL cholesterols at baseline, they still have an increased risk of cardiovascular events. In fact, they have twice the risk compared to the referent population. And as you move to the right, the higher the LDL cholesterol, the larger the odds ratio is, with an odds ratio of almost 25 for those individuals that carry an FH variant. So what this is telling us is that having an FH variant, even if you have a normal LDL cholesterol, confers additional risk. We think that this is because of a lifetime exposure to elevated levels of cholesterol, although we do not have confirmatory data at that time. But it does indicate that that doing this type of a genome-first analysis to identify individuals with FH has value over and above just measuring LDL cholesterol. So, in summary, about 54% of patients reached an LDL cholesterol goal of less than 100 at least once in their lifetime. 109, or about half the patients, had an LDL cholesterol recorded in the last 12 months, but that mean LDL cholesterol was 134, which is significantly above what we would want to see. So the conclusions that we can draw from this initial data analysis is that almost all carriers of an FH variant were previously diagnosed with hypercholesterolemia, but that an EHR review shows that a third of these patients would not have ever been diagnosed with FH based on clinical criteria, and that, more importantly, many individuals remain undertreated, and that half of our patients have never achieved an LDL cholesterol goal. Now, one of the reasons for this is that evidence is necessary but not sufficient, and it gets into the implementation piece here. So when we think about FH, we can't think about just that individual that's sitting across from us. That individual exists within a context of family members and other caregivers, and there's a team of caregivers that surrounds these individuals, including their primary care provider. In the case of the project that we're talking about, clinical genomics, cardiology may be involved, OBGYN, because if individuals are on cholesterol-lowering medications like statins, that has an impact if an individual wants to become pregnant, because statins can increase the risk for birth defects. Dietitians are important, and pharmacists. So what we're doing now is to try and implement a approach to a more integrated care that will empower patients and allow us to achieve better goals related to treatment. So again, the initiation here in the upper left-hand corner is the identification of a pathogenic variant. So we have that pre-visit, which we discussed before, but now in the context of FH, that initial visit could consist of a visit either with clinical genetics, genetic counseling, primary care provider, or some combination of the two. At that time, we would do a baseline assessment, a risk stratification, and in conjunction with the participant, determine their treatment goals. We would then initiate follow-up, which in this case would include something that we've developed here at Geisinger called medication therapy disease management, or MTDM, which is pharmacy-led care. And we found in other conditions, including some lipidopathies, that having the pharmacist leading the care team maximizes the pharmacological management, helps us to better achieve goals, and use laboratory tests more appropriately. So it's been a very effective approach in other settings that we are now going to use in the setting of familial hypercholesterolemia. And we have other team members that may be called in as needed, the dietitian, the cardiologist, OBGYN, and additional risk assessment and care. The health outcomes that we're looking at is we want to reduce the incidence of cardiovascular events. That's what we want to get to. We now have, of course, robust intermediate outcomes, including our LDL cholesterol levels, where the goal is a target of under 100 for most individuals, except for those that have had a history of a cardiovascular event, in which case we treat to a more aggressive target of 70. And we want to have process measures, which include, are we utilizing appropriate pharmacologic therapy? Are we doing appropriate laboratory testing? Now I want to conclude by returning to that face of our project to put really a story around what I've just described in a theoretical term. This individual, as part of the MyCode project, was found to have a pathogenic variant in BRCA1. We returned that result, and because she had not had a mammogram for 5 years, she had a mammogram which was normal. She was counseled per guidelines. The NCCN guidelines, which we're using for BRCA management, include an annual mammogram and breast MRI alternating every 6 months, consideration of risk-reducing mastectomy and salpingo oophorectomy, clinical breast exams periodically, encouragement of breast awareness, and then the consideration of risk reduction agents and investigational imaging. And so all of this was returned, and after several months, the patient returned to the clinic and said, after thinking about it, I'm the primary care person for my grandchildren. I need to be around for my grandchildren, so I would like to move forward with a prophylactic salpingo-oophorectomy. So this was scheduled, and she had this procedure done in August of 2016. There were no complications from the surgery, but as part of the guidelines, serial sectioning of the fallopian tubes and ovaries was done, and in the right fallopian tube, it was noted that she had a high-grade serous carcinoma that was 1.4 centimeters, and there was evidence of stromal invasion. It's important to note that we had done a pre-surgical ultrasound that did not see this, and that this patient's CA125 was normal. And this illustrates the fact that for prophylaxis of or surveillance for ovarian cancer, our tools right now are really not up to speed. A pelvic washing was also positive, and this would stage the tumor at either a 1C, although there was the potential to upstage it to a 2C because of the pathology of the tumor. This individual was started on chemotherapy less than a month later with a combination of carboplatin and Taxol. Unfortunately, as you'll recall, she also had Crohn's disease, and because of that, she had been on immunosuppression, and we needed to discontinue that because of the cancer risk, which now superseded the risk of the Crohn's disease. The guidelines recommend that this can be restarted 2 years post-treatment, but unfortunately, the patient had a flare of Crohn's disease, which has been significant. And so this is something that, from a personalized perspective, we're trying to balance the management. But I think it's very important to note that the improvement or 5-year survival for stage 1 ovarian cancer is 89%, stage 2 is 66%. If you move into stage 3, now you're dropping into the 20% or less range for survival. So we think that this detection is likely going to confer a survival benefit on this individual related to the disease. So in conclusion, genomics is an emerging technology. We have to be able to demonstrate improved value in our current delivery setting before it will be adopted. But as I think I've illustrated, implementation is very complex, and it requires a systematic approach of engagement, education, evidence, and evaluation. Outcomes must be defined, and systems must be built to support the measurement of these outcomes to determine which services really add value, so that we can emphasize those and remove services that do not add value. And ultimately, we can't forget the idea that the people that we care for are the most important, and we must consider the value from the perspective of the patient. With that, I would end and would like to thank all of our MyCode participants, which I mentioned now is approaching 140,000 Geisinger patients, our collaborators for the Discover EHR project, which includes researchers at Regeneron Pharmaceuticals and at Geisinger. The information that I presented as part of the study today reflects contributions from both groups of authors. And I'd also like to thank my colleague, Dr. Michael Murray, for use of some of the slides that he has developed. With that, I'll end, and we can open the talk for questions.
Thank you, Dr. Williams, for your informative presentation. Before we pop into the Q&A section, I just want to let everyone know a reminder for our audience on how to submit questions. Simply type them in the Q&A box found by clicking on the green Q&A button at the lower left of the presentation window. Dr. Williams will answer as many questions as time permits. Okay, let's see. The first question is, how have Geisinger patients reacted to this return of genomic results?
Thanks. That's an excellent question. Our patients so far have been, for the most part, positive about the return of results. We were concerned that they might not have remembered that they had consented for return of results, but most of them did recall that that was part of the process. We've had only a couple that have declined to have their results returned. I think a lot of the reason is we spent a tremendous amount of time before we started the program engaging with potential participants and trying to understand from their perspective what they were interested in, what they wanted. And so as we constructed the project, we were able to incorporate what they wanted into the structure. And as a consequence, the acceptance has been good. Now, that is something that we are tracking as part of our outcomes measures, the service outcomes, and we are going to be continuously improving how we're doing it to meet the needs of our participants. So we hope that this early positivity will continue as we go forward.
Excellent. Thank you so much for your answer. Our second question of the day asks, how are you contacting family members for cascade testing?
Thank you. That's an excellent question. Again, this is going to be a U.S.-centric answer. In the United States, we have certain restrictions in terms of how we can communicate information. And so at the present time, the standard of practice in genetics for contacting at-risk family members is to go through the index case, which would in this case be the MyCode participant, provide them with information that they can give to their family members, and then provide contact so that the family members can contact us directly, or if they're not in our area, we can work with them to identify genetics providers in their area. Now, that works well in theory, but in practice, not all families get along all that well. And so we have unfortunately encountered situations where someone would say, well, I'm going to let my sister know, but I'll be darned if I'm going to let my brother know. This is not an ideal outcome. And so one of the things that we're looking at is whether or not there would be certain circumstances where a family member is really not acting in the best interests of an at-risk family member, where we might be permitted to directly contact that individual about potential risk. This is a completely new area. It's not been explored. We have some experts in our research group in ethical and legal issues, and so we're hoping that we can plow some new ground here and identify better ways that we can facilitate the communication. We do provide the index cases with information that they can distribute to their family members in multiple copies to try and lower the burden on them having to describe what's going on. So far the system's worked reasonably well with that caveat.
Thank you, Dr. Williams, for your answer. We are running short on time today, so it looks like we'll have time for one additional question. What types of resources are available for participants who want to have a result returned?
In addition to what I've already described, we are working on a novel approach to develop what we're calling a patient-facing genomic test report. So this is not a laboratory report, but it's a report that is available to the patient either in printed form or ideally through the electronic health record patient portal that provides information about their result and has links to resources through URLs so they can go to patient support groups or to information resources from places like the National Library of Medicine, etc. And those reports are paired with a report that's designed for the provider, and they are paired together. And we have shown in some earlier studies that this enhances communication. The design of these reports was led by our patients and our providers. So rather than us saying, well, this is the report we're going to use, we let them design the report. And so we're looking to use this broadly within our Return Results project. And we think that this may be a way to provide information back to patients in systems where they may not have the genetics expertise that we're lucky to have at Geisinger.
I would like to once again thank Dr. Williams for his presentation. Dr. Williams, do you have any final comments you would like to leave with us today?
Once again, just thank you very much for the opportunity to present. I know that we ran short of time for questions. I believe the organizers will be forwarding written questions to me. I will get to answering them. It may take me a bit, but I will commit to answering all of the questions. And I hope that as we move forward in the field of genomics, that more and more of us will be able to move into implementing. And I hope that at least some of the information that I provided today will give you some ideas about how this might work in your respective organizations. So best of luck to you.
And a note to our audience, if we have not answered if your question was not answered today, please know that yes, your question will be answered in a follow-up email. Additionally, I'd like to thank the audience for joining us today and thank LabRoots for today's educational webcast. This webcast can be viewed on demand through May 2017. LabRoots will alert you via email when it is available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. This is Christina from LabRoots, and we hope to see you here next time at labroots.com. Goodbye.